All right, welcome everyone to the next installment of documentation dismemberment. Today we've got same non-disclosures as usual, objectives same as usual, same reminder as usual. New year, nothing has changed. Oh, Molly, you not, but you actually are not required to have any specific documentation components for billing anymore on history, review systems, and physical exam. Yeah, no, all the box checking days are past us until they reinstitute. All right, so jumping right into this case, here's the HPI. So this is an outpatient chronic case. Any thoughts on HPI other than today is Tuesday and not Friday?
Pretty complete. It's fairly complete.
It doesn't say like what he's tried for it, maybe.
Yeah, I mean, I think an inclusion of what had been tried for the pain. And obviously it's been going on since Monday. Today is Friday.
You can't say
That's 4 days.
You can say
I'm not sure if I recall that you tried anything, to be honest, so.
Is it wax and lane or wax? Wax and lane. Wax and lane. Wax on, wax off.
I think it's wax and lane.
Okay, good. I'll put that in the lane.
Because if it's only waxing, then you're in bad shape. It's the doctor.
Any other questions about that?
There's nothing added like for the treatment. Like pain what they did at home in the last couple of days.
Very.
I don't think they've done anything at home. All right, so jumping into histories. Pretty long problem list.
Got a lot of uncle there. Dystrophy, onkomycosis.
Got some nail problems.
I always wonder when I see like, surgical history, neck.
Unspecified neck, sir.
Yeah. I just.
I mean, I think that's when you get into, it's so cumbersome to document procedural history and Cerner that nobody was gonna try it for
Even anyway.
in some sort of, fusion or whatever.
Right. Or sometimes you'll even see like in the problem list, someone will just document, like elbow. And it's like, okay, and it's, something that you couldn't find the diagnosis for, and so they just put it in there temporarily, and it ends up staying for whatever reason, but it just kind of raises questions.
I like alcohol current.
Well, a little bit to be desired with the history section here, but probably not impacting the actual
No.
visit at hand. Sure.
Say we did hit a lot of nail issues all going on.
So moving on to the review of systems physical exam.
Could have done on there.
And I think it's key here. I mean, it's clearly probably auto text filled in, but making sure to do a good update to the abdominal exam when you got a abdominal sheath complaint.
Maybe noted if there was any hepatosplenectomy.
Rebound tenderness. Whether the guarding's voluntary or not.
I also would have appreciated just a little bit more specificity about like, where is this mass? Is this like a ventral? Is this lateral? Is it right at the costal margin? Like, is it near the,
The left upper.
right, it's left upper quadrant, which could be anywhere from the umbilicus to like the mid-axillary line, top to bottom, you know, like, because that changes your differential a little bit, like if it's a very ventral mass.
Yeah,
or if
I
it's like
think-
more over towards the spleen.
In the precepting of this, I think probably questionable splenomegaly would have been decent to put in here, because that was really the question of, is this the spleen or is it not? So I think throwing that out here almost like a differential was like, I'm not really sure what this is this a mass versus splenomegaly? Based on the discussion, I think would have been the appropriate way to. And
Because like,
it was more ventral.
Would you put it in the physical exam or in the assessment plan portion? Different.
I mean, you could put it either, I mean, I think either place, but I think to the point of, yeah, where is the mass? I mean, it is a little bit.
because like just reading the exam, I'm like, that could be a hernia or that could be a spleen, and those are dramatically different, like physical exam findings. But just reading that, you couldn't really tell
When you get into the location of where this was, it really did become, you know, could this be I mean, we got into Spigelian hernia differential. Probably a little higher up than that would be, but kind of in that line.
Okay.
So, you know, yeah, I think location within the left upper quadrant for something like this probably would be better. Obviously, in the outpatient setting, you're handling it yourself. It's probably going to get,
And it's not important for like billing purposes.
it's not really important, but it would be something if you had to do it again and you wanted to make it absolutely perfect, that would be something to do, I think. Because it probably was more ventral, which is with the debate over the splenomegaly, because splenomegaly you would expect to be more lateral. Whereas this was much more ventral. With thus the debate over whether it was really splenomegaly or was this a mass or what was this thing. So moving into assessment and plan.
Good plan on left of quadrant.
Renal mass will be one of them.
Yeah, I think that gets back to Alex's point of
Where is that?
where's the mass? It was so ventral, you would never really think about a palpable renal mass in a grown man's who's on the overweight side, abdomen coming out front.
He listed what, 6 differentials?
Yeah.
You could go on forever.
You could, yeah.
Pregnancy's not on there. UTI's not on there.
No, just your.
They get
Well,
notice here.
you know,
And pylorus on the differentials.
Highland probably maybe but it's just, it was a weird thing. It's like,
What is he?
I like how it says the attending's present, that we can get that level 4.
Right.
I mean, I do probably the weight loss stuff would have been better off in the HPI. It's a little bit caught up in assessment plan. And it's really more of a HPI type thing. Doesn't matter. It's going to get captured from a building standpoint, but it's a little bit out of place. But kind of wrapping around to the splenomegaly and the mono ties back to that HPI that talked about the URI a month ago. So it all comes together. I'm not sure whether the resident can document the attending's presence and get credit for anything, but
Oh, you don't think that if you put that and then build a level 4 that they'd be able to do it or no?
well, I mean, to me, if I'm looking at this from a billing standpoint and the attending doesn't document they were present, are you really going to take out a resident's word for
I
it?
guess that's fair.
I do like we captured unique physical exam.
Really was.
I'll have it.
With the guarding.
I was gonna say, I'd retract my previous, whether the guarding's voluntary or involuntary, because I did have it there. As well as,
Yeah, it's a problem.
like, weight and obesity are not always things we mention, but if that's complicating this specifically, might have been worth noting in the physical exam that, like, abdominal exam is somewhat difficult just due to patient's body habitus.
I don't think habitus caused an issue with the exam. I think patient's tenderness made it
Okay.
hard to examine.
So I thought you were saying there was some issues just palpating due to obesity.
Well, I mean,
But-
no, you're not going to palpate somebody's kidney. But
Gotcha. My misunderstanding then.
no, I was just the point of like a kidney mass would have to be so big it was protruding. The
Gotcha.
ventral abdomen would be impressive. But yeah, I mean, having the problem of abdominal involuntary guarding, I think that just helps build the case for the CT scan. And that had to be done stat.
Remember, this is Friday.
It was a Friday.
Weekend coming up.
It was Friday.
Because it's been happening since Monday. Today's Friday. That's why he put it in there, so that he can get the CT approved.
Magic words. It's Friday. So patient instructions, future orders. Really nothing exciting there.
What did it show? Oh, so I
So
thought part of
How old is the patient?
45, right?
Missing mono?
Can you make me go back now? 54, I had back. 54, like 45.
dyslexia gets us off.
Here we go.
You get flu-like symptoms like a month ago, so mono would be an option.
Yeah.
Yeah.
It certainly will.
It will. 100%. 100%.
100%.
I didn't see it. I don't know.
There's a whole paragraph on
Oh. My bad.
it. So medical decision making based on the 2021 guidelines. It's diagnosis, data, risk. The 3 components of medical decision making. Obviously, the highest 2 out of 3 will allow you to determine your final score and code level and code. Just kind of a reminder on diagnoses, we're trying to get forwards in the clinic, so always trying to figure out if you got something from a diagnosis standpoint that's in that moderate group of 1 or more chronic illnesses. Of course, what would you predict this is going to be?
One undiagnosed new problem with uncertain prognosis.
Yeah, I mean, I think it's pretty it's a new problem. You don't know exactly what it is, which is why you're having to get the labs and the CT scan. So I think that's going to get, as we move through this, this explains over a little bit more, but purpose of this, I don't think we need it. So left upper quadrant pain, I think undiagnosed new problem with uncertain diagnosis. I think the you know, some people put acute and chronic on there. To me, so much of this is specifically outlined in the HPI when this started, that you're not gonna have to explicitly call this acute to get credit for that. I mean,
Didn't it say acute visit?
Huh?
Didn't it say acute visit?
I don't know. I mean, that's what I'm saying. Your HPI is so good at explaining this just started
So good.
that, you know, nobody's gonna question.
The
You
question
know,
is,
I think if you had a chronic, I think where you would get into this is, you know, some people have this chronic, like you've seen them the third time. And now this is chronic. I think that probably something to call out too. If you, I mean, you got these people with chronic left over pain, most of them have irritable bowel syndrome. And we're just trying to get to diagnosis, but
do the diagnoses count if they're not by the number, like they're not actually entered in as a problem? Like in my actual spelling out, I did the diagnosis. Or
so because you call it a differential, I mean, you could go down through there and put every single one of those
Okay.
as its own separate, which that's the next point here is, I mean, you can put splenomegaly in, you can put pyelonephritis, you can put lymphoma, splenic infarct, hernia, all those really piling up to, you still have an undiagnosed new problem with uncertain diagnosis. To me, if anything, putting differentials in helps capture that this is an uncertain diagnosis. So it really gets you to that forward, which is one of the reasons I think Team Health hits on that from an ED urgent care standpoint. Because anytime you're playing differentials, unless one of them is something really bad, that's a threat to life. I mean, some of these are, but it's a little bit of a stretch that this guy's in here stable in clinic with some sort of crazy threat to life to get you to that level 5. So. What do you think about abdominal involuntary guarding?
That's an acute thing.
Yeah, so I think it's an undiagnosed new problem with uncertain diagnosis. That's why I got double question marks, because it's also a bad thing. I mean,
Is that peritonitis? Is it
right, I mean,
perforation?
that's the thing, is involuntary guarding then gets you into this more urgent than level 4, but I couldn't figure out how to get that. I don't know. I don't think any coder's gonna look at that and go, wow, that's a level 5 problem right there. It feels like it could be if the patient was a little more unstable. I mean, if the patient was tachycardic and had some more stuff, I think you could easily build that into a level 5 diagnosis. I don't think you got that. To get those level 5 diagnoses, you really need some other things going on to really add the argument of why. So I think, of course, abdominal, it's gonna be the same undiagnosed new problem. So what would you put the MDM diagnosis level on this one? The 4 versus the 5, if you were able to, if this were a more severe picture from a vital standpoint, I think you could build this up into a 5 if you really played up some of the differentials and you really had a toxic appearing patient. But you probably wouldn't be sending them to the pavilion to get all this done. Either going to the ER direct admitting. So you're just making sure that the logic of what you're doing goes with the level in my mind. I think if you deviate from that, the coders are not going to give you, you're not going to get credit for just saying stuff that doesn't make sense. You have to be careful. If you're trying to trump this up into a 5 and you send the guy to the pavilion to get outpatient workup, feels a little fraudulent. So data, of course, we're still, always trying to get those level 4s. Anytime you're sending somebody to get acute, like stat labs and stat imaging, I think you have to really think about, can I get to level 5? Because that's really the only time you're going to have a chance in a clinic setting is if you're having to order EKG or you're having to send them for stuff. So it's one of those things to keep in the back of your mind. But the good thing about it is if you know a level 4, you can always remember a level 4. The only difference between a level 4 and a level 5 in the data is how many categories you have to meet. So the level 4 only requires 1 out of 3 categories, whereas level 5 requires 2 of the 3 categories, but they're identical in the requirements to meet each category, so. Let's see how this stacks up. So how would you all grade this out from a data standpoint? How many category 1s do we have? So 3, so what are the 3?
CBC, CMP, and Stat CT.
Yeah, so we're ordering 3 tests, so that easily hits your 3 components there. No real review of notes or anything else mentioned. You didn't need an independent historian to talk to, an adult male here who's totally with it, so you can't get much beyond those 3 tests, but that gets you category 1. So is there any category 2? Of course, what is category 2?
2 independent reading tests.
Yeah, so it's any independent interpretation. It doesn't matter. 1 versus 5, it all counts the same.
Now, if you get the CT done and you addend your note with your own interpretation of the CT prior to the radiology read, then you could get the second one, but you could get the credit for it, right?
Does it gotta be before the?
No, it doesn't have to be before.
No, it doesn't matter the time. You can look at their reading and give you, as long as you look at it and put forth something.
Yeah.
We had CT previously, CT, like a year ago, CT, and I mentioned it in the note. As I reviewed the CT last year was not showing any mass, so we'll wait for the next.
That would be a category 1 though, right? Because that's a review of a previous test.
Yeah.
It depends.
It
If you
depends.
look, that's where you have to be very clear in your documentation, whether you looked at the report
The
or you
time.
looked at the images. That's why images independently viewed by me is a key auto text,
Yeah.
because that then says to the coder, I looked at the actual images. Because if you say I reviewed the CT, what does that mean?
No.
They're always going to score you as, well, you just looked at the report, unless you specifically say I looked at the images. Because I mean, they're not going to take it for granted that you went and pulled a whole CT from a year ago and looked through all this. But yeah, so we've got 3. So then category 3 is,
Discussion with an external
yeah,
provider.
so discussion with an external provider, can't be anybody in your own specialty. So, this is a case where had this been a little more acute and you had to call, you were suspecting, let's say it's on the right side and you're expecting, cholecystitis or appendicitis, you might call a surgeon and do those things. So it's very important to document that if you do, because that's easy category 3 credit. And you're usually, when you call somebody, you've probably ordered enough of this to get that level 5. So, hang on, we got 3, 0, 0. So EMDM on this would be,
Or
oh. And then we kind of talked through how it could be a 5 is if you get that CT images and actually document reviewing those and doing your own independent interpretation.
How accurate is the independent interpretation?
I mean, it doesn't have to be, you don't need to have a radiology level interpretation. I mean, you have to make to me, you have to get like 2 elements of it. You can't just say normal. Like, you need to actually say some specific things that you saw on there that are relevant to what you're looking for.
So with this one, it says CT scan here by myself, but it doesn't say images.
Yeah, see, this would be,
Well, it's up to the coder to decide.
this would be a bit on the edge of whether,
How does provider likes to live?
because I mean, to me, all images is the one, CT scan images reviewed by myself, done. Like, there's no gray. Like, anytime you leave gray area for a coder, that's a coin toss as to what you're gonna get. And so saying CT scan reviewed,
But they wrote cannot see on CT either when they're looking for the sub-Q message.
I mean, the story is all Gone, yeah, when we build this back, yeah.
You can make an easy assumption that you actually
Like, it's not clear.
that you actually looked at the images, but it's never explicitly stated.
Yeah,
So
I
it's up
think
to the-
because of that one, you're pushing away from the middle of the grade, but still, it's always, why not? I mean, one word could have got to black and white on this and be done. So why not? Why not throw it in there and be clear and not ever worry about whether you got down coded? Because that's gonna be a big deal as we get to the last slide of this on RVUs. So then that puts us at the category, we fill a 3, which I think because you ordered the test, you still, it's kind of it feels like double dipping, but I'm pretty sure it's kosher because you had to order it. They had to go get it done.
And it's not like you're getting paid, it's not like an EKG where you're billing for the procedure separately. You're not billing
Right.
for the
Yeah,
CT.
you
scan
can't ever
with the
bill for
interpretation.
imaging, so it's
The interpretation is
easy
just
to
part
get-
of their visit.
your category 2s on imaging because you're never gonna be able to bill for it. So now we got 1 on our category 2, still 0 on our category 3, but that bumps us up to level 5 from a data standpoint. So now we kind of we got 4 and a 5. So we're gonna make or break on risk here. So just a quick review of all the different risk stuff. So what's gonna be the key point of risk? So prescription drug management is our usual, that gets you a 4 every time if you can document that you've managed a medicine. Pretty low bar for us.
Contrast CT here. for the
In this
last part.
case, imaging gets involved. You need to know the rules of imaging. And, I think of it as low is a extremity X-ray, moderate is a non-extremity X-ray or a non-contrast CT, and then contrast CT puts you in a high. So it makes sense in the way it progresses through low, moderate, high. So just by ordering a contrast CT, this is an automatic 5. Whether you've got it done or not, I mean, you're already,
It's not mentioned here where do MRIs fall, because there's no radiation exposure, but it's still a test that's typically reserved for.
yeah, see, that's one of those weird things that sets out there that they never really, like ultrasound isn't involved either. So I don't know.
Because like an
Should be part
MRI,
of the imaging, right?
an MRI doesn't carry any inherent risk of the test the way that a CT does, and a contrast especially. So like
Well, what if you did a contrast?
contrast
MRI?
MRI, yeah.
To me, that gets you to 5, but I've never seen that explicitly called out.
Is it because maybe MRIs are not used in emergency situations a lot?
Well, but now
Or
this is the
CPR?
law of the land for all inpatient, ED, and clinic. It's all the same.
Yeah.
And this is from Team, like I actually built this off of Team Health. I mean, it's Medicare puts the thing out, but Team Health did their version of it after they updated it for hospitalists and ED. So they really didn't even have it included where that falls. So it's probably one of those things that has been updated somewhere because somebody's like, what are we doing with that? My guess is an ultrasound is probably going to get you a low because it's kind of an extremity X-ray. Well, there's not even radiation exposure,
Right.
but I would assume you get some credit for it, but it doesn't help you. I mean, a low doesn't get you anything.
Looks like
MRI,
if you find DVT with it though.
But it
that's
doesn't-
that's more on your
but-
diagnosis than the
For the,
actual
for the
risk.
risk
the
side,
risk of the test.
you only care about the risk of the test. So like even if you're ultrasounding for a testicular torsion, you don't care what the pathology is. The ultrasound itself doesn't carry any risk of making the condition worse.
Right.
Whereas like a contrast CT, you have both radiation exposure and, kidney
Yeah.
nephropathy, et cetera. So there's.
And I can
risks
see where the
associated.
MRI is probably in the same, unless you put contrast into it. There's really no risk other than claustrophobia and back pain, so. We've already talked through the risk level on this would be for each one, that's a 5 for that one.
I think I see, well, I don't know if it makes a difference.
What's that?
The CT scan's not associated with, the order is not associated with any of the diagnoses. The blood work is, but the CT scan's not. I don't know if that
I don't know
matters.
how you can't even order it without that, so I'm not sure how that happened, but it's at least already, it's explicitly called out
Up there in the,
in that
In
left
number
rear
one.
quadrant pane,
Yeah.
so. So summarizing all that, we had diagnoses was a 4 versus 5. Data was a 4 versus 4 based on the original note, but with the addendum bumps it up to a 5. That's where it's, I mean, how much time does it take? You're gonna have to call, you're calling these patients anyway to tell them results. Somebody is. So you might as well take time, look at that imaging, do that little piece of documentation and capture your 5. And so the risk is a 5. Or at the end of the day, to get a 99215, it probably was what, minute if you're dictating to put that little blurb of an addendum.
And we'll bill them a 3.
I won't build this yet.
the attending was physically present in the room.
No, the clinic visit, no.
Yeah, I was involved in this, so this is a 5. We got them.
So if somebody else,
He'll be calling when collections gets.
let's say that the night shift guy called with the CT, you couldn't, it's not gonna help your bill.
No, because it has to be from you on the data service.
Got you.
And you can't call tomorrow because now the data service is gone.
Okay.
Your face-to-face data service.
Now, if you review the images and see that everything's normal and on the date of service and record that and then ask either your colleague or, clinical staff. to
Or you
call,
could have easily had the nurse call.
Right, you can,
But
that still works. It's just,
Yes.
I
It's
reviewed this
physically
personally on the
images.
date of service.
Yeah.
That's the important part.
calling the patient doesn't get you paid anything.
Right.
Oddly, but you could bill for time, but time is a loser when you're trying to pile up clinic charges. There's not enough time in the day you could get a 5 on everybody, but the amount of time that would take, you would not win in the RVU world. All right, so how does this translate to RVUs? So we're looking at a 214 versus a 215. 214 is a 1.92. The 215 is a 2.80.
Look at vacation.
You're looking at a 46% increase in value there for what amounted to probably time you look at images and document that addendum less than 5 minutes for almost for 0.9 RVU. So that's almost half of a $50. I mean, that's almost half of a visit.
That's a whole level 3.
Yeah.
Like 5 minutes of addendum your note got you effectively an entire other 15-minute follow-up, med management follow-up visit.
So definitely worth the to capture that if you can. It's not common. So I think just remembering that that's an option for you, making some easy money. There's the usual references. Any questions? If not, we'll wrap it up.